record on this. I'll share my screen. And I'll hit play. All right, all good, everybody can see that? Thumbs up if you can see that slide. Great. All right, so I thought I'd have a little discussion with you guys about my journey with limb salvage surgery and osteosarcoma. I started getting interested in osteosarcoma when I was a surgical oncology fellow at Colorado State University in 1996, I think I started. And at CSU, we had at that time $16 million in funding from the National Institute of Health and National Cancer Institute, using canine osteosarcoma as a model for the treatment of osteosarcoma in humans. And so we had just a ton of research that was going on. And the benefit was that we were creating a lot of new information for the treatment of humans with osteosarcoma. And also we were getting funding to treat a lot of animals with bone cancer as well. So it was a really dynamic and exciting time for me. And after I left Colorado State University, I continued my interest in osteosarcoma, probably treated about 1,200 osteosarcomas in my life personally. And so it has been a journey for me in the way that I treat these things. So just as a reminder, osteosarcoma is the most common tumor of dog bone. Most commonly affects large and giant breed dogs. Remember that there's a bimodal age peak. So there's a peak at 2 years of age and a peak at 8 years of age. That relates to, the early peak relates to the accelerated bone growth that you get in dogs, particularly large and giant breed dogs at a very young age. And then you get the second peak at about 8 years of age in dogs as well. Neutered dogs are twice as likely to get osteosarcoma as intact dogs, although that disadvantage decreases if you wait until about 18 months to neuter them. And male dogs, in most studies, male dogs are probably at a slightly increased risk compared to female dogs. So the diagnosis of osteosarcoma is made on signalment and history. So if you have a large or giant breed dog with a swelling of an extremity, usually distal radius is the most common, proximal humerus, distal tibia, distal femur, proximal tibia are the more common sites that we hear. Kind of the standard away from the elbow and toward the knee is what we hear about, although we certainly have seen proximal femurs before, distal tibias before. I can't say I've seen an osteosarcoma around the elbow, but other people have reported that. The diagnosis is usually made on radiographic appearance. And so if you have this classic lytic and proliferative lesion in the, sorry, I don't know why my mouse has disappeared. So I don't have a pointer for you, sorry. But if you have this typical appearance in a typical location in a typical dog, you don't really need to do a biopsy. And I would say that 95% of the osteosarcomas that I've treated have been without a surgical biopsy until after, after we perform whatever surgery. So I'm happy to do radiation therapy. I'm happy to do a limb spare. I'm happy to do an amputation without a biopsy diagnosis prior to treatment. And I have never been wrong to my knowledge. I had one case that had an amputation and the lab locally in Australia could not find an osteosarcoma. We had already started chemotherapy. The owner was pissed that we had amputated the dog's leg, et cetera. I was very confident based on what I could see on radiographs, sent the sample to Colorado State University in the US, and they confirmed the diagnosis of osteosarcoma. You can do a fine needle aspirate on dogs with osteosarcoma, and it can provide a fairly sensitive and specific diagnosis. I think it's about 85% specificity and sensitivity for osteosarcoma, and most laboratories are happy to do that. But again, a surgical biopsy is usually not necessary. So the time you're going to do a biopsy is either if you have a lesion that looks atypical, if it's in diaphyseal bone compared to metaphyseal bone, if you, sorry, I'm just unplugging my phone here, or if you have a small breed dog or something like that, then we're more likely to do a biopsy. But in typical location, typical appearance, typical dog, we don't have to do a biopsy. So I don't know why my mouse has disappeared. Can you guys still see that? So let me just play that again and see if I can get my mouse to reappear. No, my mouse is still gone. Anyway, so pre-surgical diagnostics, we always do thoracic imaging. About 5% of dogs are going to have metastasis at the time of diagnosis. And remember that about 95% are going to eventually develop metastasis to the bones, to the lungs and other bones in some cases. The thing is that you don't want to do an amputation in a dog that already has metastatic lesions in its lungs, because the survival time is going to be really limited. We do blood work for two reasons. One is to look at alkaline phosphatase, which is going to give us some prognostic indication. So an elevated ALP in a dog that does not have liver disease and is not on steroids is a poor prognostic indicator. And then some laboratories can actually give you the bone isoenzyme of alkaline phosphatase, which is again prognostic for long-term survival. We will do, or we used to do bone scintigraphy when I was at Colorado State University. And this is an example of the bone scintigraphy over here on the right, where you can see areas of bone production or destruction light up. The problem is that it can be too sensitive. So if you have areas of degenerative joint disease or an old fracture or something like that, it can light up. And so it's too sensitive. And so I have not done bone scintigraphy since I left Colorado State University in 1998. Somebody did try to publish a paper which looked at whole body CT as a screening test for metastasis or osteosarcoma and found that it was not of any benefit. It wasn't sensitive or specific enough to pick up metastatic lesions. If you're thinking about doing a limb salvage surgery, you ought to do some kind of imaging of the leg. Generally, CT scan or MRI is going to be more sensitive and specific for the extent of the tumor than just normal radiographs. And I was a co-author on a study that looked at radiography and scintigraphy compared to histopathology, but I'll review that in a minute. And I can't even, let me just escape again. I just cannot understand why my mouse isn't showing. Can you guys still see the presentation? All right, so this was the study that I was co-author when I was at Colorado State University, where we looked at the accuracy of X-rays compared to scintigraphy and histopathology for determining the proximal extent of the distal radius osteosarcoma in order, because you have to decide where you're going to make your cut in the bone. And so we found that radiography underestimated the length of the tumor and scintigraphy overestimated the extent of the tumor. That same study I don't think has been done for CT or MRI, but that's something that would be interesting to look at. So limb spare candidates, you want minimal invasion into the surrounding soft tissue and bone. Can you guys see my pointer there moving around? Okay, so this is an example of a case that has really extensive soft tissue involvement, and it's not one that would be appropriate for a limb salvage surgery, because if you removed all the soft tissue component, you'd be left with just a naked bone sitting there with no coverage at all. We like the tumor length to be less than 50% of the length of the bone. And distal radius is the bone that's most amenable to limb salvage surgery. You can do ulna as well, anywhere in the ulna, and actually anywhere in the diaphyseal bone of any of the long bones you can do limb salvage surgery on. But the one, the kind of the classic one, is the distal radius. Obviously, absence of the pathological fracture is a good idea, although people have gone now and surgically repaired pathologically fractured bones with actually surprisingly good results. And that's not doing a limb spare. So you're not going in and removing the tumor bone and replacing it with an implant. You're just going in and plating that fractured bone, and that can actually do quite well. Obviously, you want no evidence of metastasis on your pre-op staging, because if you have metastasis, you're going to have a significantly worse survival time. And is it worth putting a dog through a $5,000 or $6,000 or $7,000 surgery and chemotherapy and stuff like that if the prognosis is only for a couple of months from the metastasis? So the ideal limb spare technique, you want biological affinity for the host tissue. So ideally, you would want some ability for the bone to grow into the implant. You want the procedure to be resistant to infection, and you want sufficient biomechanical strength and resilience to support the leg. So you want function in the leg after the procedure. So this is my limb spare implant that I developed back in the late 90s and early 2000s. I did about 100 cases using this implant system, and I'll go over a little bit about what the progress was in my development of this implant. So this is an example of an endoprosthesis. So when we're putting in a prosthetic that's inside the dog, it's called an endoprosthesis, and this is one that's sputter coated with titanium. So you can see how rough that is there, the idea being that you're going to get bone ingrowth into the endoprosthesis. So with any limb salvage surgery procedure, you're going to have complications, and that's why in most cases we recommend amputation. So limb salvage surgery is really only for dogs that can't handle an amputation, or for owners that can't handle an amputation. So with most limb salvage surgery procedures, you're going to have an infection rate of around 50%, a recurrence rate of around 25%, an implant failure rate of around 25%. And all that being said, you still have good to excellent function in about 90% of cases, and the majority of dogs are walking the day after surgery on the leg. I will have a discussion with you a little bit more about infection. My recurrence rate is lower than 25% because my threshold for doing a limb salvage surgery is probably lower than other people. And so I want one that's going to be more likely to be successful, less likely to have recurrence. I was a co-investigator on a couple of different studies where we looked at the survival time in patients with infection after limb salvage surgery, and found that the survival rate is double in infected patients compared to uninfected patients. And so the survival rate with an infected limb spare is about 2 years, and with an uninfected limb spare is about 1 year. And I started a PhD at Colorado State University looking at trying to characterize the immune response that's resulting in that improvement in survival. And I got about 6 months into it, and then I got a full-time faculty position, and so I abandoned my PhD study. But what's probably happening is that you're getting a non-specific immune stimulation, and the cancer cells are getting attacked as kind of an innocent bystander when the body's fighting the infection. It doesn't matter how long the infection lasts, or what the bacterium is, or what the antibiotics that they're on. It's a pretty universal response that we get to that infection. So the original procedure that was done for limb salvage surgery was a cortical allograft, and that was developed at Colorado State University in 1993, 94. And that's before I arrived there. And that was done by Dr. Rod Straw and Dr. Steve Withrow. Rod is practicing in Brisbane, and Steve, I think, is retired. But the first limb salvage surgery that they did took 14 hours. They were so careful to try to protect all the blood supply and everything. Now I can do a limb spare in about 1 hour and 15 minutes or 1 hour and a half. So that just gives you an idea of how things have progressed. You can be a lot more cavalier about the blood vessels that are involved, or that are whether spared or sacrificed in the leg than we used to be. One benefit of an allograft is that it allows osteoinduction and osteointegration, meaning that if the dog lives long enough, often this will become one bone. Okay, so that is a big benefit as far as biomechanical strength, because you don't have as much issue with failure of the proximal construct with an allograft that you do with my endoprosthesis. Downside is that you have to have a bone bank. In Colorado, we had 250 bones in a bone bank, all stored at -80°C, and you could match the bone with the size of the patient, right or left, et cetera. Turns out that you probably don't need to do that. You just need a piece of bone in there. It doesn't matter if it's a right radius or a left tibia, as long as the two ends or the ends of the bone meet up to the allograft. It doesn't really matter what bone you use. The alternative is to harvest a bone specifically for a particular patient, and I have done that in Australia since I don't have a bone bank available. This is what they look like in surgery. So you've got your allograft that's in here, and it's plated in place. Most limb salvage procedures require an orthodesis of the carpus adjacent to the allograft or the endoprosthesis. We haven't really found a good way to preserve the function in that carpus, but the fact is that, again, 85 to 90% of these dogs are going to have a good to excellent outcome. So the next technique that you can do is called an autograft. So an allograft is taking another bone from another patient of the same species. An autograft is when you're taking the bone from the same patient. And with a lot of these autograft procedures, what we're doing is we're taking out the tumor bone, sterilizing it with one of these 4 different procedures, and then filling it with bone cement and reimplanting it in the same patient. And so pasteurization is a low-level hyperthermia for an extended period of time. Autoclaving is a high temperature for a short period of time. Irradiation is you just irradiate it. So normally if we're treating a dog with palliatively with osteosarcoma, we're going to do 32 gray of radiation divided into 4 treatments. Whereas when you're doing a limb salvage surgery using radiation, you're doing about 80 gray of radiation all in one setting, and then reimplanting the bone. And then freezing is another procedure that I have done before, where we take the bone out, dip it in liquid nitrogen for about 15 minutes, and then reimplant it in the patient. I've got some photos of that coming up. When I got into private practice in Virginia, I didn't have a bone bank, and limb salvage surgery was a big part of my practice. And so I started autoclaving bones. I did 9 cases like that. And what I would do is autoclave the bone and then fill the medullary canal with bone cement, reimplant it in the patient. What I found as I followed these patients radiographically is that the bone basically completely dissolved away, and all that was left was the methyl methacrylate core. And so then I started saying, okay, I'll just make a bone table side. So I would mold a bone at the table at the time of surgery and then just screw that into place. And then I thought, well, if I'm using methyl methacrylate, why don't I just use a metal implant? And so that's when I started the design of my metal endoprosthesis. So this was a case where I irradiated the tumor bone in situ in a dog, and I'll show you the video. Oh, it's not going to let me show that on YouTube. Let me just see. So I'll just have to switch over to, so I'll stop the share here and start the share. We also did intra-operative radiation therapy on the patient in order to prevent recurrence. If you have any comments or questions, please place them on the YouTube site. Thanks. Okay, so can you guys see that view? All right, so this was, let me just mute the video. So this was a kind of a metaphyseal osteosarcoma, the humerus in a dog. And you can see that thickening of the bone and the bone cortex and stuff, and you can also see some lysis of the bone here. And so what I did was, I'm just continuing on here, in surgery, I incised over the tumor bone, and then I exposed the entire bone and amputated out that biopsy tract. So you can see that biopsy tract right there. Then I completely isolated the bone and then packed it off. And then I created a window, kind of a coffin top window in the bone, scooped out all of the bone cancer. And then I packed lead around it and then irradiated it. So here I've packed it off, and I'm picking out all of the tumor bone out of the inside of the medullary canal. So that's that coffin top window that I've made into the bone. And then I'm scooping out all the bone tumor, and I'm just trying to totally isolate this surgical site from the rest of the dog so that I'm not going to implant cancer into the rest of the patient. And so then once I did that, I isolated the tumor bone with lead around the bone, the back of the bone and everything, and then took it to our radiation machine and then irradiated it, just gave a huge dose of radiation through this opsite or ioband drape. And then I came back into surgery after having irradiated it, took all the lead out, filled it with methyl methacrylate, and then plated it to provide some support to that bone. I've only done one case like this, but Let me just go back to our YouTube video. Sorry, I'll stop the screen share and then reshare that. Share. Can you guys see that dog sitting there? All right, so this was the day after surgery. Go ahead. So just incredible function. And basically we just preserved basically all the muscles. Like the only thing that I cut out was the triceps muscle and the back, long head of the triceps. And that dog lived about 18, 19 months before it developed metastasis. So diaphyseal limb spares can do really, really well. Now, the other way that they do radiation therapy, this is called the flip and nuke procedure at Colorado State University. So the flip and nuke, so they cut the proximal end of the radius here and then elevate it up, basically pull it out of the leg while maintaining the collateral ligaments and everything in the carpus, and then just irradiate the shit out of it through the bone. And that's where they're giving about 80 gray of radiation, and then they come back and plate that into place. And they did, I think they did 30 odd cases at CSU, found that their biomechanical failure rate was quite high. And so they started doing some different things, but basically that's been totally replaced with SRT, which is stereotactic radiosurgery, where you don't have to do any surgery at all, although they will often go back in. And so you don't have to cut the bone at all, but they will go back in and plate the bone afterward to provide some biomechanical support. This is another case I did. I did 3 of these where I took the tumor bone out, soaked it in liquid nitrogen for 15 minutes, and then reimplanted it. And you can see that you get, the nice thing about this is that you get a perfect fit with the autograft. And we didn't have any biomechanical failures. And there's another potentially beneficial aspect to this that that may come into play. And so the benefit is that if you take mice that have been genetically modified to accept human osteosarcoma, and you implant those osteosarcoma in the bone, and it starts growing and it metastasizes, if you go in and pull out that tumor bone, freeze it, and then put it back in, they saw regression of the metastatic lesions. And so what's happening is that you're basically creating a tumor vaccine by freezing and lysing all of these cells. You're killing the tumor, but exposing the body to the tumor DNA and all the antigens and stuff. And so you can actually cause it to attack the metastatic lesions as well. I didn't do enough cases to really know whether it made a difference, but it's really interesting and kind of exciting. And we know that with oncology, we have medical oncology, we have surgical oncology, we have radiation oncology, and now we have immuno-oncology, which is where the real advances, I think, in survival are going to be made. And that's your tumor vaccines, melanoma vaccine, things like that. So that was really interesting. There's another procedure called an ulnar transposition. And that's where you take the tumor bone, cut it out, and then move the ulna into the radial position. And you try to do that on a vascularized pedicle or vascularized leash. And the exciting bit about that is that because you're putting in a vascularized implant, your infection rate drops down very, very low. And in fact, one retrospective study by Seguin et al., they had, I think, 0% infection rate. Then you're losing the benefit of infection that you get with survival, but the quality of life is going to be better in those patients that don't have an infected limb spare. Even if you get where you lose your vascular pedicle, you can still bring the ulna in and then just use it as an autograft, and that's still very effective as a procedure. The downside is that if you are going to get recurrence, usually that recurrence is going to be within the ulna, because the interface between the radius and the ulna is the place where you get most likely to get dirty margins. And so what I'll do if I'm doing an ulnar limb spare is that I'll sacrifice the distal end of the ulna, and I'll bring my autograft from higher up in the ulna and then bring that down into the radial position. And so that eliminates or reduces the likelihood of local recurrence. There's another limb spare that was developed by Nicole Earhart, who was one of my coworkers at Colorado State University and also one of my intern mates. And what she did where she did bone transport osteogenesis. And so what they would do is that they would make a little cut up here and then put a little piece of the bone, which is non-cancerous, on an external fixator and gradually drag that piece of bone down. And you can see here that it's creating new bone as it goes. And that's what they do in humans as a leg lengthening procedure. If you have people that have dwarfism and that kind of thing, they can grow their bones longer by doing bone transport osteogenesis. And then at the end of basically you're adding about 1 millimeter a day of length. And so you just twist the little screws to get 1 millimeter of movement a day, and you can generate a whole new bone here and then dock that down to the radiocarpal bone. And they also had no infections except for the pin tract infections that you would get. The downside is that the dog has an implant like this on for 90 days or 100 days, or however many millimeters of bone that you need to produce. And then also you have to do the docking procedure at the end of the bone transport to reattach it down to the radiocarpal bone. This is, again, the metal endoprosthesis that I developed. And this is what it looks like radiographically. Now, these are a couple of cases that I did. The benefit is that you just pull it off the shelf. It's a very quick and easy procedure. The downside is that you do get, well, at the time of surgery, it's biomechanically superior to an allograft. You get similar infection rates. We did see a high incidence of shearing biomechanical failure in the proximal implant. And so now we've started putting, or they've started putting in locking screws in that proximal end of the implant, which is improving the biomechanical stability of these. Note that with limb salvage surgery, you're never going to get fail down here in the metacarpal bones. It's always going to be in the proximal radius. And so my plate that I developed has 8 screw holes distally. You could probably get away with 3 or 4 down here because you really, you just never see failure down here. It's always going to be up here. You do have a much faster operative time and there's no need for a bone bank. Then you get the next level, which is a custom endoprosthesis. And that's where you scan the contralateral leg and you 3D print an endoprosthesis, which is custom made for that patient. Again, I think that that's probably overkill because it doesn't really matter what you're putting in here. You could have one size fits all implant. If it was titanium and sputter coated so you can get some bone ingrowth, you're going to get exactly the same outcome as you're going to get with a 3D custom implanted or custom produced implant for that patient. The other thing that they do with these is that they plate them to 2 bones distally in the metacarpal region. But again, we never see failure down here. And so there's really no reason to do that. So I think that this is more of a gee whiz, that's cool, but it doesn't really provide any benefit to the patient. This is the 3D custom implant that's been produced. I think this was done by Noel Fitzpatrick in the UK. He has his own 3D printing laboratory that's next to his hospital. And so he has made some pretty cool things, but again, I question whether that's of huge benefit to the patient. One place that it is interesting is that this is one of his that he's created a 3D custom implant for an acetabular proximal femoral osteosarcoma. And so this is something where creating an implant specifically for that patient would be of benefit. And this is Noel Fitzpatrick in the middle with some of his implants. This is an endoprosthesis that was 3D custom printed for this dog. And this is an ITAP, which is where you have an external component where you do a distal limb amputation, and then you create an implant that docks on the inside of the bone up here, and then you can do interchangeable prosthetics on the outside of the leg. So doing limb spare on other bones, this is another paper that we did at Colorado State University for humeral osteosarcoma, and we found that out of 17 dogs, 2 of them had acceptable function. And so that is not a procedure that I've ever done clinically. So this is for the proximal humerus where you're orthodesing the scapulohumeral joint. The problem is that it's really difficult to reattach all of the important muscles that are going to provide support to the leg on the forelimb, like your triceps, your biceps muscle, deltoids, things like that. It's just very difficult to reattach those and get acceptable function. Now, there's another procedure that was developed by Sarah Boston. It's called a Bostonplasty, where instead of putting in an implant, you're just taking out that tumor bone and creating a shorter radius. And she, I think, has done 2 cases, and she published one of them and found that that the function was actually quite good. It's interesting, when you look here, you can see the bit of ulna that's just been cut to allow the leg to shorten, and it's just kind of floating out there in space. I have not done a limb shortening, limb salvage surgery, but I think that it's an interesting prospect. Benefit being that your infection rate is going to be lower. You don't have to have an implant. You don't have to have a bone bank or anything like that. Now, this is what they're doing in humans, where they'll create a custom implant that's articulated. And so they'll go in and remove that tumor bone and replace it with an implant that's got a strut that's going up into the medullary canal. And then you replace the proximal tibia with a polyethylene platform, and then you have to replace the collateral ligaments as well. And so that's kind of where things are going, certainly in humans. Again, the question is whether it's worth developing an entire system like this for dogs when they do so well with an amputation. Now, this is really interesting. These are for kids. What they have is basically a motor that's run with magnets, and the kid sits in this magnet every couple of weeks. And what it does is that this gantry is spinning, and it turns a motor on the inside of the leg and gradually lengthens their limb spare implant so that the implant grows with the patient. So that's really interesting, because a lot of these kids are going to be 12, 13, 14 years of age when they get bone cancer. And if you do a limb spare that fits a 12 or 13-year-old when they get to 18 or 19, especially since these are commonly going to be in tall, rapidly growing kids, that implant's going to be too small. So you can actually grow the implant as the patient grows. The other thing that they'll do in humans is, particularly so they won't do it for osteosarcoma because that's too invasive, but for things like Ewing's sarcoma and bone cysts and things like that, they'll create a little window in the bone, put a funnel in there, and actually fill the bone in situ in the patient with liquid nitrogen and kill all the tumor cells around it. And then they'll pull the funnel out and fill it with bone graft. So that's another option that they do in people. This is an ITAP, ITAP, which is the it's a prosthetic, and I can't remember what ITAP stands for. If anybody knows, put it on the chat. It's where you've got that strut that's going up into the medullary canal, and then you can get different exoprosthetics that fit on the on that strut. This is what they look like clinically. Try to get some hair growth. The problem is that often it's hard to get the skin to adhere to the implant. And so my understanding is that the outcome isn't that great with these guys. Now, this is another implant that was done at Fitzpatrick. Let's see, we've got an implant, intraosseous transcutaneous amputation prosthesis. Thanks, Dylan. I figured it was going to be you that came up with that. So that's intraosseous transcutaneous amputation prosthesis. So this is another 3D implant that was created for a stifle in a dog. And the problem with this is that the leg is so long, that single bone is so long that you get inadequate function, just like when you try to do a stifle arthrodesis in a dog. So let's see if I can bring this up on YouTube. And I'm just going to change my screen sharing, go over to Chrome, share. Can you guys see that? Proximal limb spare, tibial limb spare. So this is a proximal tibial osteosarcoma. They've gone in and created 3D scan, the CT scan, the opposite leg. And what's really nice about the 3D scanning is that you can create a cutting guide that fits exactly onto the patient. And So that's the 3D construction, and you get this cutting guide that fits onto the bone, and then it has the holes that are created with the cutting guide fit into the screws fit in there, and then also the bone saw fits right into the slits in the cutting guide. And so once you pull that guide off, your implant is going to fit exactly on that patient. So this is the tibial component, fits right onto the bone. So this is pretty standard operating procedure in humans. It's not done very commonly in animals. So then that implant is going to absolutely perfectly fit onto that bone. Now, again, the problem here is that you've got a stifle that's orthodesed, and so the function, that leg is basically going to be just too long for the dog to get good function. So that was the procedure when it was happening. That was not, sorry, it was not Noel Fitzpatrick. So this is the dog using the leg, and you can see he is using it, but it's just really just throwing the leg out there. And I can tell you with reasonable certainty that this dog would have done just as well, if not better, with an amputation. So again, some of this is, gee, this is a cool procedure that I want to try, but it might not be, might not be the best thing for the patient. So let me go back to my presentation. So this is another one that I had not included previously, but it's called a Manus transfer. And what we're doing is we're taking out the tumor bone and then just arthrodesing the carpus to the distal ulna. Okay, so Manus transfer, where basically we're transferring, we're laterally translating that carpus relative to the antebrachium. And then you put in a conventional limb spare plate, and then you add an SOP plate along the side. Benefit of that is that you don't have an implant in there that's going to contribute to the development of infection. You don't have to have a bone bank. You don't have to buy an endoprosthesis. And this seems to be quite interesting as an option for limb salvage surgery. So that's pretty much that presentation. Let me just close my screen share. So do you guys have any questions or comments about osteosarcoma in general or limb salvage surgery specifically in dogs? Just put it on the chat if you have any questions. That's just a little taste. Okay, so how about putting some frozen tumors subcutaneously and then put in some bacteria, the BCG, that's an endotoxin that was created as an immune stimulant. So frozen tumor bone subcutaneously is something that's really interesting, and I have thought about doing that myself. Haven't gotten around to doing it in a patient, but I think that would have a lot of appeal as far as creating kind of that tumor vaccine for the patient, but it's not something that I've done. I have thought about it. So stem cells, the concern about stem cells are that there are some laboratory studies that show that if you put stem cells in animals, laboratory animals that have cancer, it causes the cancer to grow uncontrolled. And so my general tendency, and this is based on the advice of the stem cell company, is not to put stem cells in patients that have cancer. Any other questions or comments? So that's kind of a whirlwind review of limb salvage surgery in dogs. Is the periosteum the margin that we use? Yes, that's correct. So we do use the periosteum. So you're not trying to get 2 to 3 centimeter margins on these things. You're just using the periosteum. And because these tumors are expansile, they expand from the inside out, but they don't tend to penetrate outside the bone in most cases. We would screen these for, again, that soft tissue invasion on a CT scan before we do limb salvage surgery. BMP, or bone morphogenic protein, is something that you can use, and particularly with the titanium coated endoprosthesis, Sometimes they'll use bone morphogenic protein in the area to try to get bone to grow into the implant. Any other questions or comments? We've got about 20 minutes left. Any risk with the soft tissue margin? So we rarely see recurrence in the soft tissue. Usually it's going to be in the ulna at that interface. Any other questions about anything related to vet surgery that you'd like to discuss? All right, well, we'll go ahead and leave it at that. Hope everybody's having a good week, and we'll have a good weekend, and we will see you again soon. Thanks, guys.